Dear Chairman, thank you very much for this presentation and the opportunity to be there again. Great choice. So it's a very nice question, but difficult to answer. I would like to try to make it simple. Why do we need the anticoagulation after TAVI? Because of valve thrombosis with going to stroke and coronary stent thrombosis with acute myocardial infarction. So, in fact, anticoagulation after TAVI depends on the patient. A patient without indication for anticoagulation, it's very important to know that. Patient with previous coronary stent will be treated during the first 3 months, and then patient with mandatory indication for anticoagulation. And this cartoon from Greco shows that after TAVI, we have to deal with leaflet thrombosis, stroke, and MI, with concomitant anticoagulation, which will lead to bleeding factors over times, early bleeding and late bleeding. Early bleeding with the vascular access and the procedural anticoagulation, and then the late bleeding with considering with the comorbidities, the age, and the chronic antithrombotic unnecessary therapy. So it's clear that atrial fibrillation will have an impact on mortality, contrast to the sinus rhythm patients. This is to take into consideration. This paper from Vora shows clearly that in terms of stroke, mortality, and MI, atrial fibrillation is a major risk factor. So there are variable strategy of anticoagulation in absence of clear recommendation. We can see on the left patient without indication of oral anticoagulation, and majority is on DAPT. And on the right, patient with indication of oral anticoagulation, we see that there is a clear majority of patients with a combination of VKA plus antiaggregants. And so this is just to mention the valve thrombosis after TAVI, which is easy to diagnose with echo and then confirmation with CT. And the treatment is clear, and also it reoccurs if treatment stops. So the societal guidelines, it's amazing to see that it is really unclear, and it leads to the previous slide, which is that everybody is doing his own cooking. The Canadian Cardiovascular Society position in 2012 was quite interesting, based on the data we had at this time. Now we need definitely trials, and we will go to those trials. The trials without indication to oral anticoagulation, and the trial with indication to oral anticoagulation. So we will go through RT, Popular, Galileo, Atlantis, and then going back Popular for the indication of anticoagulation, and Atlantis and Envisage. So patient with after TAVI without indication of anticoagulation, historically it was DAPT for a reason I don't know. Practically, it shows that apixaban does not reduce stroke in Galileo, and DAPT versus aspirin alone. The very important trial from Rodez-Cabot with Arte shows that DAPT will lead to more bleeding. So basically, if no stent, aspirin or clopidogrel alone is perfect. If stent, then there will be just DAPT for 3 months, followed by aspirin or clopidogrel alone. So ART trial in JACC 2017, aspirin is better than DAPT because it avoids major bleeding and major complication, as well as it does not reduce stroke, MI, and death. So this meta-analysis shows that clearly already in 2018, we know that for this population, just one antiaggregant is better than 2. So Popular TAVI is going after in the population without anticoagulation, showing clearly that aspirin is better than DAPT because the DAPT does not decrease the stroke, but increase clearly the major bleeding. So what about NOACs versus aspirin in patients without indication for anticoagulation? And clearly, the Galileo showed that there was no interest, and it was in fact interrupted because MACE in the rivaroxaban group, so Galileo was interrupted. So Atlantis trials with two groups, a group without indication and the group with indication, and basically from those first results from ACC, it shows that there is no need for oral anticoagulation in the population without indication of anticoagulation. Now let's go to the group of patients with indication of anticoagulation. Should we add antiaggregants? And so there are different questions of this, and the France TAVI registry, not trial, but registry with 25,000 patients included, and 88,000 patients treated with oral anticoagulation. It appears in this registry that NOACs are doing better in terms of reduction mortality, reduction of major bleeding, in contrast to VKA. So these data are not randomized data. This trial from Seeger in 2017 showed that, in fact, apixaban is doing better than VKA in terms of mortality, stroke, at 30 days follow-up. It's very important to know at what time, what is the follow-up. And in contrast, when we discuss about anticoagulation plus antiaggregation, and the study of Altisent in 2016 showed that, in fact, the VKA group without antiaggregant, without aspirin, does better. And with aspirin plus anticoagulant, then you have definitely increased major or life-threatening bleeding. So now let's go to the popular TAVI, the arm with indication for anticoagulation. And it shows clearly that oral anticoagulation alone is doing better than with clopidogrel because, again, of bleeding. So bleeding is clearly shown with both without or with indication, with the fact that we want to do better and we do worse by adding antiaggregants. So, envisage edoxaban with, in comparison with VKA, again, in contrast with what we saw with the France TAVI, the edoxaban does not do better than VKA and is worse for bleeding. So, very important work from De Backer showing that the stroke in TAVI compared to the control population is definitely increased at the very beginning, but not in the late phase, which means that in our guidelines, we should have in mind that there are different times for employing the anticoagulation. So, I would like to finish on this very important work on new atrial fibrillation, which is an underestimated risk after TAVI. Detection of TAVI by a pacemaker in this study of Megali show that, in fact, you have 25 new atrial fibrillation with 14.5 subclinical detected via the pacemaker over 15 months. So This leads to 12.5% in new AF in patients with sinus rhythm. And this is very important to know, is there a need for identifying this population? Can I have my last slide?
Can you give him extra minute, please?
Thank you very much.
Just only 1 minute, Dr. Lafont.
So this is a very important question. How should we look at this new atrial fibrillation? So in conclusion, patient without indication of anticoagulation, single platelet therapy is based by ARTE, popular TAVI, and no anticoagulation in this population without anticoagulation because of increased bleeding. In patient with indication of anticoagulation, clearly it is not necessary and it is worse to add platelet therapy with anticoagulation. And regarding VKA versus NOACs, it seems from the trials that VKA are safer in terms of bleeding based on Envisage and also on Atlantis. And if contraindication of anticoagulation, and then I think the story of the LA closure is very important and should be confirmed. Thank you very much.